Good morning. A warm welcome to Online Anaesthesia, the postgraduate teaching program on Zoom platform, sponsored by Acrola and hosted by Logics. And it's also simultaneously aired by Anaesthesia TV. Thanks to Anaesthesia TV. Today we are hosting the critical care series second week. There are two important topics and a video demo today. The first topic is invasive hemodynamic monitor that deals with arterial line CVP pulmonary artery catheter by Dr.P.Aarthi. And second topic is non-invasive hemodynamic monitoring by Dr. Prateema. That will be followed by the video demo of insertion of CVP by Dr.Sasi Mayukha. So today's session is coordinated by Dr. Rajesh, Jeyaprakash. Over to you, Rajesh, sir.
Good morning, sir. Good morning, one and all. Welcome to our online anesthesia postgraduate teaching program. This is a critical care series. As we all know, mother anesthesiology has various subspecialties with opportunities to do super specialization in particular field, especially critical care. Today, we have three eminent speakers who took up anesthesiology per se as their career to get transformed into intensivist. So, our speakers for today's session are Dr. Aarthi, Dr. Prateema, and Dr. Sasi Mayukha. We welcome you all. And the first session will be on hemodynamic monitoring, invasive modes by Dr. P.Aarthi. She's a senior consultant of Multidisciplinary ICU from MGM Healthcare, Chennai. He started his career as a critical care medicine general medical officer, then get transformed into anesthesiologist, then into critical care physicians. He got enormous training in various areas, especially she got trained in UK for many long years and very passionate towards critical care medicine. I know her from her postgraduate days, how much she's dedicated to critical care, an ideal person to deliver this lecture. Over to you, Aarthi, to start with your lecture on hemodynamic monitoring.
Thank you, sir. Thank you for the introduction. So at the outset, I thank the organizing committee for this opportunity. So let me go into the talk. So good morning, everyone. My topic today is about invasive hemodynamic monitoring with emphasis on arterial lines, in the sense arterial blood pressure monitor, central venous pressure monitoring, and pulmonary artery catheter monitorings. So why do we bother about this invasive hemodynamic monitoring? So at the outset, we need to understand the hemodynamic instability, whatever the cause may be, is called as a circulatory shock. So this circulatory shock leads to many complications. So patients who survive the initial phase of shock with respect to even in critical care or perioperative period may then go into what is called as multi-organ failure, secondary to microcirculatory dysfunction, which is a major cause of late death if this circulatory disturbance is not addressed appropriately. Hence, we need to monitor the hemodynamics to assess the global and regional tissue perfusion to prevent hypoperfusion and hence to prevent circulatory shock and hence to prevent the long-term and short-term morbidity and mortality. So appropriate and early application of diagnostic information from hemodynamic monitoring has been shown to reduce mortality with respect to shock. So coming to specific emphasis on surgical patients, we talk about a lot of hemodynamic monitoring in critical care patients where we know that the patients are critically ill with a lot of multiple reasons for their circulatory dysfunction and extensive comorbids. So with the special emphasis for surgical patients, the surgical patients are high risk for hemodynamic instability because they are increased risk of hypoperfusion, secondary to vena cava compression due to positive pressure ventilation, and reduction in the muscle tone causing redistribution of blood flow secondary to drugs used during anesthesia, and also the compensatory mechanism to maintain normothermia to compensate for starvation and secondary to inflammatory response causes increase in oxygen consumption at the outset of decrease in the deliveries. So these situations put the patient in a very high risk position, leading on to circulatory disturbance. So why are we worried about these circulatory disturbance is that they cause secondary organ dysfunction like myocardial infarction, stroke, renal failure, and bowel ischemia. So hemodynamic monitoring should include a combination of clinical examination, monitoring devices, and laboratory results. The focus is always about the patient, not the technology. In practice, the monitoring devices are employed in series of increasingly invasive and complex steps depending upon the clinical examination and patient's response to the treatment. So the recent fluid challenge and intensive care trial indicated that there is a considerable gap between accumulating knowledge about the benefits of advanced hemodynamic monitoring based on optimization and actual clinical practice. So whom do we call patients are high-risk patients with respect to surgical are patients with previous severe cardiorespiratory illness like acute myocardial infarction, chronic obstructive pulmonary diseases, or patients with history of stroke, and patients who have vascular diseases involving the major vessels, old age patients more than 70 years with limited physiological reserve, patients who undergo extensive surgeries like esophagectomy, gastrectomies, and acute abdominal patients with peritonitis or perforated viscus, patients who have massive blood loss, patients who have septicemias, sepsis, and septic shock features, patients who are having respiratory failures and acute renal failures. So all these patients are high-risk surgical patients and high-risk patients in critical care units where we need to monitor them in an invasive methodology. So I'm going to talk about three monitors: arterial line monitoring, central venous pressure monitoring, and pulmonary artery catheterization. So coming into the arterial blood pressure monitoring, arterial blood pressure monitoring is a cornerstone of hemodynamic assessments. So the definition of low arterial pressure is patient-specific and always interpreted in the context of patient's usual blood pressures. So what are the indications of arterial monitoring are patients who are having unstable blood pressures or who are anticipated to have unstable blood pressures, patients who are in severe hypotension and who needs rapidly acting vasoactive drugs like vasodilators, vasopressors, and inotropes, and also for frequent sampling purposes, patients with severe hypertension and other supportive devices like intra-aortic balloon pump, and patients with unreliable and difficult to obtain invasive blood pressure. So these are all the current indications for invasive arterial blood pressure monitoring. There's another upcoming indications for arterial blood pressure monitoring is monitoring of systolic pressure variation or pulse pressure variation with respect to the arterial waveform analysis in patients who are mechanically ventilated. And this is an important step in assessment of preload and fluid responsiveness, which I will be talking about shortly. So we just to brush about the arterial systems, I'm not going to go into the details, just going to brush the knowledge. So it is an catheter which is inserted into an arterial axis, either in the radial, brachial, femoral, etc., where it is connected to the fluid transducer system. And that system has a pressure sensitive diaphragm, which is transmits the pressure changes into the monitor. And this is connected to the pressurized flush bag with the pressure about 200 to 300 millimeters of mercury. So to prevent clots and to prevent convenient meaning of testing the fast flush test. We need to know about certain specific parameters with respect to arterial blood pressure monitoring. So those are a few definitions which we need to understand before going into the assessment. So dynamic response is an important ability of the arterial system to accurately reproduce a patient's hemodynamic waveform. So that depends upon two things. One is the resonant frequency, another is the damping coefficient. So the resonant frequency of the system is the frequency at which the system oscillates when it is stimulated. Okay, the resonant frequency is also called as the natural frequency of the system, and it has to be greater than the highest frequency of the incoming pulsatile arterial blood pressure signals. Otherwise, the waveforms will be exaggerated or it will be damped. So, for example, if the natural frequency is greater than 20 Hertz, which is normally we expect it to be, so that it can faithfully reproduce the arterial pressures with a frequency of heart rates between 120 to 60 beats per minute, that is between 2 Hertz to 1 Hertz. So what is damping coefficient? Damping coefficient refers to how quickly this oscillating arterial fluid-filled system comes to rest. So the system with high damping coefficient will diminish the arterial waveforms, and the system with a low damping coefficient will exaggerate the signals. So how do we assess the dynamic response of an arterial system is using a fast flush test. So a fast flush test is to briefly open up the fast flush system to produce a square waveform. So this, you can see the diagram there. The first one represents the optimally damped system, where after the square waveform, you get 1 or 2 oscillations, and underdamped systems have more than 2 oscillations, and an overdamped system have less than 1.5 oscillations after the square wave test. So overdamped systems, where the reasons being presence of air bubbles, kinks or clots in the pressurizing tubing system, or even the loose connections, or a compliant tubing. So all these things will cause over damping of the system, and also the underinflated pressure bag. If the pressure bag is less than the pressure 300 millimeters of mercury, this also causes over damping of the system. So what happens with the over damping is that the blood pressures are read falsely low. Systolic blood pressure is falsely low, and the diastolic blood pressure is falsely high. The mean arterial pressures are usually not changed. And with this analysis of the arterial waveform, the diacrotic notch is diminished or absent with respect to the overdamped arterial system. Coming to the underdamped system, the causes could be a compliant tubing, where the natural frequency is exactly equal to the signals transmitted by the arterial system, and usually results in overshoot of the systolic pressures, causing vibration and spikes. So that's the same thing. So these are all the various definitions we need to understand with respect to arterial blood pressure monitoring. So coming to the invasive hemodynamic monitoring with respect to the arterial blood pressure monitoring, we have important parameter, what is called as pulse pressure variation. So pulse pressure variation is a difference between the arterial systolic and diastolic pulse pressure, diastolic pressure. And that's the definition of the pulse pressure. So pulse pressure variation refers to the difference between the maximum pulse pressure and the minimum pulse pressure over a single mechanical breath. So this pulse pressure variation is analyzed with respect to patients on positive pressure ventilation. So to document the inspiratory and expiratory respiratory waveform should always be simultaneously analyzed when you're assessing for a pulse pressure variation with an arterial waveform. So pulse pressure variation can be calculated manually or automatically. So these are the calculations which is done manually. So almost all advanced monitors have automatic devices to calculate the pulse pressure variation. So pulse pressure variations of more than 13% has been shown to be specific and sensitive indicator for preload responsiveness. It's almost 90% specific and sensitive with respect to preload responsiveness. So what do we normally see? The principle behind is that the pulse pressure reflects the left ventricular stroke volume, which indirectly reflects the cardiac output, which indirectly reflects the hemodynamic status of the patient. So this is one of the dynamic indices which we monitor the pulse pressure variation and also the stroke volume variation. It is derived from what is called as heart-lung interaction during the positive pressure ventilation. So what happens during a positive pressure ventilation is that during the positive pressure ventilation, the vena cava is compressed, preload is decreased in fluid responsive patients, which results in decrease in the stroke volume, and hence decrease in the pulse pressure during inspiration. A patient is defined as fluid responders if the decrease is greater than 13% from the baseline with respect to pulse pressure and more than 14% with respect to systolic pressure variation or stroke volume variation. A patient is defined as non-fluid responders if the stroke volume variation or the pulse pressure variation is less than 9%. And there is always a gray zone between these two numbers, 9 to 13%, where the clinician have to take a decision with respect to the clinical manifestations or move on to a different modality of invasive hemodynamic monitoring. So looking at the picture, picture A represents a pulse pressure variation in a non-fluid responding patient, and B represents the pulse pressure change in a fluid responsive patients. So with respect to the arterial blood pressure monitoring. So coming to the contraindications for arterial blood pressure monitoring is anticipated thrombolytic therapy, patients with severe peripheral vascular diseases preventing catheter insertion, and vascular anomalies like local aneurysms or hematomas, and lack of collateral blood flows. For example, when the radial artery has been used for a previous coronary artery bypass grafting. So coming to the central venous pressure monitoring. So central venous pressure is often considered as a good index of volume status. However, there is strong evidence of poor correlation between the CVP tracing and the patient volemic status or fluid response. But still, we use central venous pressure monitoring in both surgical and critically ill patients because of the following reasons. So the CVP is not a good responder for fluid responsiveness because it is influenced by many other factors like the peripheral vascular tone, right ventricular compliance, pulmonary vascular resistance, and in patients who are ventilated, it doesn't reflect the right blood pressure. It is usually on the higher side. So CVP can be a useful indicator as an upper threshold at which stopping fluid therapy. For example, a positive trend reaching a higher value may inform the clinician that there is no more need for fluid replacement. And it should not be considered as an absolute target of fluid therapy. So elevated CVP does not necessarily indicate adequate preload and should not prevent a fluid challenge if indicated. So what are the indications of central venous catheter insertion is to measure the central venous pressures, infusions of vasoactive drugs, and patients who are hemodynamically unstable and who are undergoing major surgical procedures, and inability to obtain a peripheral vascular access, and use for hemodialysis, plasma exchange, and transvenous spacing. So relative contraindications would be severe coagulopathy, anticipated thrombolytic therapy, an infection of the overlying site, and thrombosis of the superior vena cava or the subclavian vein. So normal central venous pressure is around 0 to 5 millimeters of mercury in a spontaneously breathing patients, and the upper limit of normal would be 10 millimeters of mercury in a mechanically ventilated patients. And a CVP of more than 15 millimeters is always pathological. So it could be volume overload, it could be a right ventricular failure, or it could be secondary to pulmonary, congestive cardiac failure, or it could be even due to tension pneumothorax. So CVP should not be regarded as a single parameter. It always has to be guided with the clinical condition of a patient, and trend of CVP analysis has to be done. So just to brush up the knowledge, CVP tracing has 3 positive waves and 2 negative deflections, A wave, C wave, and V waves. So A wave is due to atrial contraction. It is normally lost during atrial fibrillation, and Kennan A waves are present during junctional rhythms or third degree heart block or ventricular tachycardia. C waves is because of it happens during the early systolis bulging of the tricuspid valve during the ventricular contraction, and tricuspid regurgitation causes fusion of C and V waves causing and blunting of the X descent. And V wave is secondary to the rapid filling of the right atrium. And in tricuspid regurgitations, V wave is prominent. And so in atrial fibrillation, there is loss of A waves, and in tricuspid regurgitation, there is prominent V waves. And in ventricular premature contraction, there is Kennan A waves, and in pressure overload, there is fusion of complexes with a prominent A waves and steep X descent. So now coming to pulmonary artery catheters. Pulmonary artery catheters are 7 French catheters, which is normally the length ranging from 90 to 110 centimeter long, used for right heart catheterization. So there are different models of pulmonary artery catheters. So these are basic thermodilution models where you measure, these catheters are used to measure the right atrial pressure, pulmonary artery pressure, pulmonary artery occlusion pressures without intermittent thermodilution or cardiac output measurements. So this is a basic basic model, which just measures the right heart pressures and pulmonary artery occlusion pressures. The other model, which include addition of infusion ports where there are lumens which open into the right atrium or the right ventricle, along with the measurement of the pressures, they are also used for continuous drug infusions and fluid infusions. And there are models which aid in measuring cardiac output continuously. So this includes measurements of right atrial pressure, pulmonary arterial pressure, occlusion pressure, along with a thermal filament with a catheter tip that would continuously provide to monitor the stroke volume and cardiac output monitors. There are more advanced devices where you have oximetric catheters, where at the tip they have a fiber optic devices which allows to continuous monitoring of the mixed venous oxygen saturation. And additional parameters to measure the right ventricular ejection fraction, where a thermistor is incorporated to beat measurement of the temperature change. So these are all the various different types of pulmonary artery catheters available. So just to refresh the knowledge about the basics of pulmonary artery catheters, is 110 centimeter long. The catheter markings occurs every 10 centimeters. There are markings made at every 10 centimeter points so that the length of the catheter is identified easily. So there is a distal port which opens to a lumen running the length of the catheter, terminating at the step. Okay. So the port opens or measures the pulmonary artery pressures or pulmonary artery occlusion pressure, and this port is utilized to sample mixed venous blood. The balloon inflation port opens to a lumen that terminates with a balloon located at the tip of the catheter. The balloon is inflated with 1 to 1.5 ml of air to facilitate passage through the heart and to wedge the catheter to obtain the pulmonary artery occlusion pressure. And there are two ports. A proximal port opens at 30 centimeter from the distal tip, and it is used to measure the right atrial pressures and infusion of fluids. There are another proximal port which is located 26 centimeter from the distal tip, which is also used for infusion of fluids and monitoring. A protective sheath is extended along the external length of the catheter attached to the introducer. So where do we normally position these catheters? So pulmonary artery catheter has to be positioned in the west zone 3, where we need to have a constant blood flow, which happens in zone 3, where the pulmonary arterial pressure is greater than the capillary pressure, which is greater than the alveolar pressure. So how do we identify that the pulmonary artery catheter is ideally positioned? Is that while measuring, the pulmonary artery diastolic pressures are always higher than the pulmonary artery occlusion pressure, and the catheter tip should be below the level of the left atrium on a lateral chest X-ray, and the visible A and V waves are seen as a cardiac ripple when you have a wedge monitoring waveforms. And changes in the pulmonary artery occlusion pressure is less than half the changes in the PEEP during a PEEP trial. So these parameters tells us that the pulmonary artery catheter is ideally positioned. So this is a normal pressure tracing as we move from the right atrium to the pulmonary artery wedge pressures. And these are all the normal lengths at which the each chambers of the heart is achieved using the pulmonary artery catheters. So right atrium usually at 10 to 15 centimeters, right ventricle at 20-25 centimeters of the catheter. Pulmonary artery is usually 35 to 50 centimeters. So the normal right atrial pressures would be 0 to 6, where you see as a central venous waveforms. And once the right atrium is, right ventricle is reached, there is a pressure shoot, a systolic pressure shoot to up to 15 to 25 millimeters of mercury, and reaches a baseline from the to the right atrial pressure. And once we move from the pulmonary artery, right ventricle into the pulmonary artery, there is a diastolic upshoot. That is, the systolic pressures remains the same between, similar to the right ventricle, 15 to 25 millimeters of mercury, but the diastolic pressure increases to 6 to 12 millimeters of mercury when the catheter tip is in the pulmonary artery. Once the catheter is wedged appropriately, it measures pressure range between 16 to 12, and you would see this cardiac ripple kind of a picture that has A and C wave pattern. So there are normal variables which are measured using a pulmonary artery catheters, and there are derived variables measured after using formulas from the basic variables derived from the pulmonary artery catheters. So cardiac output can be derived using a pulmonary artery catheters, and hence cardiac index can be calculated. Central venous pressure is documented using the right atrial port, and the pulmonary artery wedge pressure is documented when the pulmonary catheters are wedged, and pulmonary arterial pressures are monitored, and also the mixed venous oxygen saturation and central venous oxygen saturation as well can be obtained using the pulmonary artery catheters. From these measured variables, the derived variables like stroke volume index, systemic vascular resistance, and pulmonary vascular resistance are calculated using the formula. So why do we worry about the hemodynamic monitoring? So coming into, so we have brushed our knowledge about arterial pressures, we have brushed our knowledge about the central venous pressure monitoring and the pulmonary artery catheters. So with these three parameters, what are all the hemodynamic parameters which we can monitor using these invasive monitors? We need to understand why do we chase these values. So preload, afterload, and the cardiac output are the parameters which can be monitored using these devices. Preload is defined as a myocardial distension before a systole, and which, with respect to Frank-Starling relationship, the myocardial contraction force depends upon the muscle fiber stretch, which is exactly the preload. And afterload is the resistance against which the ventricles must push the blood. And the European guidelines suggest that apart from the clinical assessment, all these parameters should be guided with the physical examination, with the basic monitoring devices, and along with the advanced hemodynamic monitoring devices. So why is that pulmonary capillary wedge pressure helps to guide the preload? How is that wedge pressure reflects the preload of the left ventricle? So left ventricular preload is an important determinant of cardiac output. So LV preload can be defined as the left ventricular end diastolic volume, which is an important determinant of left ventricular end diastolic volume is the left ventricular end diastolic pressure. So LV end diastolic pressure is a close reflection of the left atrial end diastolic pressure as the ventricles fill from the atria, and we assume that both the atrial and the ventricular compliance are normal. So in those scenarios, the left atrial end diastolic pressure is similar to the left ventricular end diastolic pressure. This left ventricular end diastolic pressure is the preload with which the heart has to pump the blood, which directly responds to the cardiac output. So left atrial pressure is the pressure measured when the pulmonary arterial catheters are wedged. So it reflects the left atrial pressures. So this diagram explains the wedging of the catheter. So once the catheter is wedged, there is no flow happening. So the pressure measured at this point distal to the wedging will reflect the left atrial pressure, assuming that the left atrium, left ventricular are complained and there is no downstream obstruction distal to the catheter tip. So, but then there are certain clinical scenarios where there are increase in resistance or non-compliant left ventricle where the pressure might be higher. So the wedge pressure might not relatively reflect the left atrial pressures, which we'll be seeing when that does happen. So pulmonary arterial wedge pressure, normal instance will reflect the left ventricular end diastolic pressure. But there are certain scenarios where the pulmonary arterial wedge pressure is not the direct reflection of the left ventricular end diastolic pressure. So for example, when there is pulmonary venous resistance, high pulmonary venous resistance, the distal pressure is the measured pressure is higher actually. So pulmonary capillary wedge pressure will be higher than the left ventricular end diastolic pressures. And also when the catheter is not wedged in the appropriate position and when there is still flow in the wedge that is not properly wedged, still flow in the catheter distal to the wedging. And also certain scenarios where the pulmonary arterial wedge pressures are lower than the left ventricular end diastolic pressure. So for example, in aortic regurgitation and mitral regurgitations where the pressures on the left side of the heart are higher compared to the capillary wedge pressures. And also when the left ventricle is non-compliant and there is also patients on positive pressure ventilation where there is excessive intrathoracic positive pressures. And left ventricular end diastolic pressure may not predict the left ventricular end diastolic volume. So we assume that when measuring a pulmonary capillary wedge pressure, that left ventricular end diastolic pressure is a direct correlation of the left ventricular end diastolic volume. So which is the cardiac output volume. So in certain scenarios, that might not be the true case where the LV is poorly complained, for example, post-myocardial infarction or a left ventricular hypertrophy, where the left ventricular end diastolic pressures are higher. And also, for example, in patients with cardiac tamponade. So, and also where a RV is over-distended and that compresses the LV and causing increase in the left ventricular end diastolic pressure, which might not relatively reflect the left ventricular end diastolic volume and hence our cardiac output. So with so much of complex scenarios and so much of observed variations and with a lot of technical difficulties, why do we still rely on pulmonary artery catheters? There are certain indications where the pulmonary artery catheters will give us additional information about the patient's hemodynamic status. For example, when the cardiac output measurement, especially in the patients with arrhythmias or aortic balloon pump, where other invasive hemodynamic monitoring devices cannot be used, where the pulmonary artery catheters can give us an insight about the hemodynamic status of the patients. And unequal right and left ventricular failure, complex hemodynamic instabilities where the patient presents with combination of shock features like obstructive cardiogenic or a hypovolemic shock. It's a combination of scenarios where the pulmonary artery catheters still have a role. And to differentiate between cardiogenic pulmonary edema from a non-cardiogenic cause, and also certain indications like to titrate the pulmonary antihypertensives in ARDS, where we use nitric oxide or prostacyclin for pulmonary vasodilatation, and also in scenarios where there is reversible systolic heart failure like myocarditis and peripartum cardiomyopathy, where these pulmonary artery catheters aid us in managing the hemodynamics of the patient, and also in differential diagnosis of pulmonary hypertension, and also transplant workup for cardiac and pulmonary transplant patients. So what are the contraindications for pulmonary artery catheters? As obvious that the right side of the heart, where there is a tricuspid or pulmonary prosthesis or vegetations and endocarditis in general, and there is a mass in the right side of the heart, and there is delicate structures in the heart. For example, if the patient is already having a transvenous pacing, and patients with severe tricuspid or pulmonary stenosis, and also extremely thinned atrium or ventricle. So these are all the contraindications wherein we are unable to use a pulmonary artery catheters. So coming to certain insights about studies based on the PACs. So initially, the first study was done in 1973, which was published by Krexel, where they infused volumes to patients with low filling pressures and administered diuretics for those patients who were pulmonary artery wedge pressures were on the higher sides. So they were able to reproduce the Frank-Starling's curve and act upon these repeated real-time estimates, where the pulmonary artery catheters came into clinical practice, where the anesthetists, critical care physicians were using more and more of PACs. And the publication that first weakened the PAC was in 1996, where a JAMA study showed that 5,735 critically ill patients were associated with, they reported the increased mortality and increased length of stay and increased cost with respect to PACs. And finally, the myth was broken with a Pacman trial, that is pulmonary artery catheters in patient management trial, which conducted between 2001 and 2004, provides the strongest evidence, states that the PACs neither benefit nor harm the patients broadly defined in ICU populations. So pulmonary artery catheter measurements are subject to significant operator errors and physiological variations that complicate interpretation and response. So what are the recommendations? As I said earlier, the indications of PACs based on the guidelines: patients with high risk for complex cardiac interventions, in severe low cardiac output syndromes, and patients with high pulmonary hypertension, where you have to have the diagnosis and differentiation between the severe right and left ventricular dysfunctions. And there is no role for PACs in a low perioperative risk patients at present. So these are all the overviews about the invasive monitors. So now coming to the most important parameter which we assess during the hemodynamic instability is the cardiac output. So hemodynamic status monitors measures the ability of an individual to deliver, ability of the organism to deliver oxygen to the tissues. So tissue oxygenation is consequently determined by oxygen delivery, which is in turn determined by the product of arterial blood oxygen content and the cardiac output. So cardiac output can consequently be considered as a good index of tissue oxygenation given a sufficient blood oxygen content. So cardiac output is determined by the preload, afterload, contractility, and heart rate. So there are monitors which are used in assessing the cardiac output. So these are all the various monitors and methods which are used to measure the cardiac output in different scenarios to give the status of the hemodynamics of the patient. So as I was talking about earlier, pulmonary artery catheters are used to measure the cardiac output using what is called as pulmonary thermodilution technique. This pulmonary artery catheter can either be used as a single step catheters or to monitor continuously the cardiac output using a thermal filaments. And there are other monitors like PICO and volume view, which utilizes transpulmonary thermodilution technique. So they can either use a single measurement or it uses the continuous monitoring devices where it has to be calibrated. For this PICO or volume view, one need to have a central axis and also the arterial axis either in the femoral, brachial, and arterial axillary lines. This transpulmonary thermodilution technique, which is measured using a PICO or volume view devices, also measures what we call it as extravascular lung water, which is a very important monitor in assessing the risk of patient developing a pulmonary edema. The other method of assessing cardiac output will be a transpulmonary indicator dilution technique, where we use lithium as an indicator, where the need for central axis or a peripheral vein can be used, and the monitor is attached to the arterial line, and the changes in the indicator concentration derives the cardiac output. And there is other monitors where we assess the cardiac output through arterial pressure waveforms. So this LIPCO device, flow track, and Vigilio uses this algorithms. There are different waveform algorithms which are computed and analyzes the area under the arterial line curve, and just gives the stroke volume and hence the cardiac output of the patient. There are other monitors as well. I'll just brief about it. Esophageal Doppler and partial carbon dioxide rebreathing circuits. And I think the non-invasive hemodynamic monitoring will be more emphasized on the bioimpedance, bioreactance, etc. And also the gold standard, the transthoracic and transesophageal echoes are monitors which provides valuable information about the cardiac output and hence the hemodynamic status of the patient. So let's just brush a knowledge about the basics of these few parameters which are used in the hemodynamic monitoring devices. Coming to the indicator dilution or thermodilution. So whatever the methodology, they can either use a dye, or they can use a saline, or they can use a cold saline which assesses the temperature change, or a dye which uses the concentration change of the indicator. So the principle will be to assess the cardiac output is based on that the rate of blood flow, hence the cardiac output, can be determined from the rate of change in the concentration of a substance after a known amount of it has been added to the bloodstream. So Stewart Hamilton arrived at an equation where flow is directly proportional to the dose of the indicator and inversely proportional to the concentration time curve. So either an indicator or a temperature change is analyzed, and then a curve is formed, and area under the curve is analyzed using the formula, and then the cardiac output is documented or measured with the following formula is indicator dose divided by the area under the concentration time curve. So this is basically the indicator dilution technique. And Stewart Hamilton modified this indicator dilution technique with a formula which includes the computerized constant or injected temperature change to assess the cardiac output with respect to the thermodilution technique. So moreover, it's almost a similar formula which is slightly modified in thermodilution management. So when an indicator dye is introduced, into the system, a known volume of indicator is added to the bloodstream. And then at the distal end, the concentration of the indicator is plotted against a time and the area under the concentration curve, and with the known concentration, one can derive the cardiac output. So what is the advantage of this over the standard fixed method of measuring the cardiac output is that there is no need to access the mixed venous blood or arterial blood. It is convenient with the electronic calculations, and cardiac output measures can be automated and it can be made continuous, and it correlates well with the gold standard measurements of cardiac output. So all these thermodilution techniques also provides us with various other parameters to assess the hemodynamic status of the patient. So temperature falls between the injection site and the measured site proportional to the cardiac output. These systems also permit indirect calculations of what is called as the extravascular lung water index as a measure of pulmonary edema, which is helpful in guiding the fluid administration. And there is also a static parameter, what is called as the global end diastolic volume, which assesses the preload, which is more reliable compared to the central venous pressures or the pulmonary arterial diastolic pressures. But then patients with severe right-sided valvular regurgitation, intracardiac stents, concomitant infusions may impair these kind of cardiac output measurements. So just an overview about what we phrase it as in thermodilution technique or indicator dilution technique. Indicator or a cold saline is injected into a central venous axis and the measured at the distal end, either at the proximal arterial axis or a radial axis. So the thermal volumes are calculated using various formulas. So these are all the different thermal volumes. So this is the temperature distributes into different chambers of the heart, which provides different information about the thermal volumes into the in the intrathoracic system. So with the area under the pressure curve, we monitor the cardiac output. So with that, along with the mean transit time and other parameters, one can derive the intrathoracic thermal volumes. So the whole volume in the intrathoracic space includes called as intrathoracic thermal volume, and also one can derive the pulmonary thermal volume. So when you exclude the intrathoracic pulmonary thermal volume from the intrathoracic thermal volume, one can get what is called as the end diastolic volume. So global end diastolic volume is the volume of the blood remaining in the heart at the end of the diastole, which predicts the preload. So once from there, one can calculate the intrathoracic blood volume. So once the intrathoracic blood volume is identified, extravascular lung volume can be calculated and derived from the above parameters. This extravascular lung volume is a volume present in the lung in the pulmonary interstitium or alveoli, which predicts the whether the individual will be more prone for pulmonary edema. So what are the limitations of these kind of thermodilution techniques are? When you use a dye, the use of dye limits the frequency and repeatability of the measurements, and manual integration of area under the curve is laborious, and automated calculations of cardiac output involves correction factors and coefficients, which then reduces its accuracy. And this method relies upon uniform mixing of the blood and the unidirectional flow. So when these things are altered, the cardiac output is not directly proportional. Under laboratory conditions, it almost similar to the margin of 25% with the direct method, with a fixed method of measuring the cardiac output. So to put it in, to summarize it, so there are two major forms of assessing the cardiac output using an invasive monitor. One is transpulmonary thermodilution, and another one is a pulse contour analysis. So earlier I was talking about the transpulmonary thermodilation. So why is it transpulmonary? Is it that the dye or cold saline is injected into a proximal vein, and then the change in the concentration is measured at the distal arteries. In a Pitco system, it is measured using a femoral artery, and in a lithium or dye dilution, it is measured using a peripheral arteries as well. So that is a transpulmonary thermodilation. The difference in the concentration is plotted against the curve, area under the curve, which helps us to derive the cardiac output and the global end diastolic volume, intrathoracic blood volume, extravascular lung volume, and other parameters like pulmonary vascular permeability index. So with all these parameters, one can assess whether we need to push in more fluids or give them a diuretic or add more inotropes or vasopressors. In case of pulse contour analysis, the arterial waveform is analyzed and the area under the systolic portion of the arterial curve is plotted. And then there are different techniques used, analytics used to measure and derive the cardiac output. So they derive is what is called as pulse contour cardiac output. So they also gives us a measure of the arterial blood pressure, heart rate, stroke volume, and these pulse contour analysis helps us to assess what we earlier talked about, the stroke volume variation and the pulse pressure variation, and also they measure the systemic vascular resistance. So these are the different techniques which are used in different monitors to assess the arterial waveforms. In Pitco technique, as I was mentioning, they analyze the area under the curve, and in case of Litco lithium curve, the pulse pressure analysis is the methodology used to analyze the arterial waveform. And in flow track and Vigilio, the dynamic tone with multiple measurements are done analyzing the multiple waveforms to derive and mention the stroke volume or indirectly and directly the cardiac output. So to summarize, the pulmonary artery catheters use what is called as indicator dilution technique. And with that, one can measure the cardiac output either continuously or in a single stage, depending upon what type of pulmonary artery catheter we are using. And pulse contour analysis is what I was talking about earlier, analyzes the arterial waveforms, which are minimally invasive. There are both calibrated and uncalibrated techniques, and these can be used for continuous monitoring of the stroke volume. And also they also give us about the stroke volume variation, which predicts the responsiveness of fluid status. So coming to another important parameter, which we analyze using a pulse pulmonary arterial catheter and also the central venous catheters, either the mixed venous oxygen saturation or central venous oxygen saturation. This central mixed venous oxygen saturation is obtained from the scaval blood sampling. It is less invasive and fairly correlates with the mixed venous oxygen saturation. So oxygen extraction is about 25%. Okay, of the total amount of blood delivered to the peripheral tissues when it is completely oxygenated by the arterial blood. This results in 75% oxygen saturation in the central venous hemoglobin. So in the central venous oxygen saturation shows earlier patient hemodynamic imbalance prior to other hemodynamic or lab value changes, and it considered a valid endpoint for shock resuscitation. So oxygen saturation less than 60 to 65% has been shown to predict adverse outcomes. And mixed central venous oxygen saturations show early patient hemodynamic imbalance, and oxygen saturation, I have repeated the same. So it's alone determines a hemodynamic status. So when central venous oxygen saturation is high, it can either be a decrease in the delivery or it can either be due to increase in oxygen consumption. So decrease in delivery secondary to anemias or bleeding, hypovolemia, heart failure, or increase in oxygen consumption where there is sympathetic overactivity secondary to pain, agitation, shivering, and fever. So all these scenarios will cause a decrease in the central venous oxygen saturation. Certain situations where the central venous oxygen saturations are higher, for example, when there is septic shock, where the microcirculatory dysfunction happens and the oxygen consumption is reduced, and in surgical patients where hypothermia, sedation, analgesia, where the metabolism reduced, the consumption is reduced, whereas increase in delivery of oxygen happens during transfusions and excessive fluid challenges and inotropic use. So all these scenarios will have a higher central venous oxygen saturation. So now coming to, so we have discussed about how do we interact different invasive hemodynamic monitors. So now we need to understand that what are the complications related to these invasive hemodynamic monitors. So in patients with arterial blood pressure monitoring, one need to be very sure about zeroing. Zero reference point is very, very important with respect to measurements of arterial blood pressure in different scenarios. When you're measuring a cerebral arterial perfusion pressure, 0 point is different. And when we are measuring an arterial blood pressure to assess the cardiac output, the zeroing is different. And the damping coefficient is very, very important. When the system is either over-damped or under-damped, that might not give an adequate or appropriate blood pressure tracing. And with respect to CVP, as I was telling you earlier, decreased right ventricular compliance, tricuspid valvular diseases increases the central venous pressures. And in positive pressure ventilation also, central venous pressures are overestimated. And in patients with intra-abdominal pressure high, for example, in laparoscopic surgeries, the central venous pressures may be artifactorily elevated. We were more talking about this pulse pressure variations and stroke volume variations. So as I was telling you, these are derived from arterial waveform analysis using various interpretations and various technologies. So there are certain checklist validation criteria for which these stroke volume variations or pulse pressure variations are ideal for patients who have these following checklists. So the patient has to be on controlled mechanical ventilation without any spontaneous effort. And the ventilation should be a tidal volume of 7 to 8 ml per kg ideal body weight. There should not be any closed chest conditions. In the sense, open chest injuries should not be present. And the patient should not have any forms of arrhythmias, and the compliance of the lung should be normal so that they transmit and we can able to understand the heart-lung interactions during the positive pressure ventilation. And these patients are unaffected by the valvular heart diseases that should be excluded. And we assume that the right and the left ventricular functions are synchronized and coordinated, and the normal abdominal pressure as well. And so these are all the validity criteria checklist where the pulse pressure variation or the stroke volume variation reliably predicts the cardiac output. So in certain situations, when there is extreme tachycardias or extreme bradycardias and high frequency ventilation, the pulse pressure variations may be falsely negative. And in case of irregular heartbeats like atrial fibrillation, the pulse pressure variation might be falsely positive. And when patients are ventilated with low tidal volumes in ARDS kind of a picture, that might also give us a falsely negative values. And in case, for example, in laparoscopic surgeries, that might increase the intrathoracic pressure and that might give false positive values during assessing the pulse pressure variation. And these, when there is open chest injuries and when the patient is spontaneously breathing, they might not relatively predict the pulse pressure variation, and stroke volume variation might not predict the cardiac output. So, so to summarize the parameters used to assess the invasive hemodynamic monitoring, there are static parameters and there are dynamic parameters. Static parameters, as we are aware, are the central venous pressures and pulmonary artery occlusion pressures. And these static parameters reliably reflects the preload only when the patient is in the steep form of the Frank-Starling's curve. Once the patient is in the horizontal or in this slope of the curve, then they might not relatively reflect the preload of the heart, this static parameters. So then comes your dynamic parameters. So static parameter also has this global end diastolic volume and left ventricular end diastolic volume. So these are all the measures used to assess the static pressures. Now coming to dynamic hemodynamic monitors are the pulse pressure variation and the systolic pressure variation and stroke volume variation. These three variations rely on the heart-lung interaction of the positive pressure ventilated patients and assess the preload predictability. And there are certain checklist criteria where these parameters are reliably predicts the preload of the patient and also the fluid responsiveness of the patient. So we need to understand that from which patient perspective and which ideal patients where these monitors can be utilized. So, and coming to other parameters, which I was talking to you earlier, is the PICO and the LITCO monitors. So in earlier, the pulmonary artery catheters, where I was telling that you can utilize as continuous cardiac output monitors or a single stage cardiac output measurements can be monitored using a pulmonary artery catheters, and lithium dilution technique, where you insert an arterial line and the dye is inserted through the central or a peripheral axis, and the change in the dye concentration reflects your cardiac output. So this measure, these PICO and LITCO are all minimal invasive monitors where they need to be calibrated. And flow track, where it just assesses the pulse pressure contour and it doesn't need to be calibrated. So to summarize, how or what type of monitors we can utilize in patients with acute circulatory failure. So when we have a low blood pressure or low cardiac output or signs of tissue hypoperfusion, then you need to assess whether you need to give fluids or restrict fluids. So when there is fluid loss or in patient with septic vasodilated shock, it is obvious, then we need to go for volume expansion. And when we are unable to judge whether there is fluid loss or a volume loss or there is a shocked state where there is a systemic vasodilatation, then we need to understand whether we need to assess the clinical picture of the patient, whether the patient is spontaneously breathing, is the patient is having any cardiac arrhythmias, or are we using any low tidal volume ventilation. If no, then we can assess the pulse pressure or stroke volume variation using arterial monitors like flow track, and respiratory variations of IVCs and SVCs can be assessed using an echo monitors, and all other parameters like passive leg rise and expiratory occlusion tests and mini fluid challenges, all those things can be utilized in those scenarios. When patient is spontaneously breathing and the patient has a cardiac arrhythmias, or the patient has been ventilated with low tidal volumes, which normally happens in most of the critically ill patients, then we have few other parameters to go about is the passive leg rise test and end expiratory occlusion test and mini fluid challenges. So these are all the monitors advised in the surgical patients. So usually the advanced monitoring is utilized in medium to high risk patients, all the monitors which was discussed earlier. So as the risk progresses, the monitoring involved also becomes more and more invasive. So there are a few questions which are answered in perioperative hemodynamic optimization, a guidelines implementation with an expert panel. There are a few questions which we normally ask, and I could find this paper useful, so that I thought I will just put on these questions and answers by the expert opinion as well. So which blood pressure goal should be targeted during anesthesia and perioperative period? The expert opinion was, we proposed to prefer continuous invasive arterial pressure monitoring in moderate to high-risk surgical patients, ideally using an algorithm-based approach. As I said earlier, the algorithm which is used to assess the blood pressure monitoring, preventing and managing hypotension. So what is a MAP target? The MAP target will be above 65 millimeters of mercury, or patients with hypertension, then you need to understand that it should be between 10 to 20% of the preoperative reference testing values. So our dynamic indices like the pulse pressure variations and stroke volume variations and many others predict and manage volume expansions. So as we discussed earlier about the validity criteria checklist should be performed before using the pulse pressure variation to estimate fluid responsiveness, and also to give small fluid boluses to assess the pulse pressure change or responders. So responders are those who have a pulse pressure variation of more than 13, and patients are unlikely to respond to fluid who have a pulse pressure variations of less than 9%. And alternative assessment of pulse pressure volume change is the end expiratory occlusion maneuvers or a mini fluid challenge. So when we do an end expiratory occlusion maneuvers or a mini fluid challenge, a 3.5% absolute increase in the pulse pressure variation during the transit raise in the tidal volume is a good predictor of fluid responsiveness, and an absolute decrease in the pulse pressure variation more than 2% during a mini fluid challenge is a predictor of fluid responsiveness. So when should we measure stroke volume and cardiac output? We propose to use mini or non-invasive continuous methods to monitor cardiac output or stroke volume rather than invasive reference technique implemented in the perioperative global directed therapy in moderate to high-risk patients undergoing non-cardiac surgery. And as the clinical scenario becomes more and more complex, and when the patient's need for invasive monitoring increases, then we implement more and more invasive monitoring. So we also need to talk about the economic impact or hemodynamic monitoring for the goal-directed therapy. So that has to be definitely looked upon about the economic impact of the advanced hemodynamic monitoring used. And a few words about hemodynamic monitoring in cardiac surgeries, because cardiac surgery patients undergo rapid changes in cardiac performance and vascular tone that may diminish the accuracy of other monitors and requires the clinician to rapidly differentiate between early signs of shock like bleeding, graft occlusions, and tamponade. So these areas where PACs play a major role, where they have technical and selection criteria can be overcome because they use very frequent and they're more familiar with these pulmonary artery catheter techniques. So coming into the evidence, pulse contour analysis in postoperative CABG patients have a good correlation with the gold standard pulmonary artery thermodilation techniques, and also like measurements like intrathoracic blood volumes and pulmonary artery occlusion pressures using a PAC catheter is recommended in major cardiac surgeries. And CVP alone is not a good predictor of volume status, and mixed venous oxygen saturation could actually contribute along with other parameters to assess the hemodynamic changes. So algorithm in patients, indications for advanced hemodynamic monitoring in a cardiac surgical patients is when the patient has hemodynamic instability and you have an obvious STT changes, then if the patient is intubated, you go for a transesophageal echo. And if the patient is not intubated, transthoracic echo. Along with that, at 1 lead ECG and a mixed venous oxygen saturation will help us to assess the further hemodynamic assessment. When there is a low cardiac output status and the patient undergoes a high-risk cardiac surgery, then along with the transesophageal echo or transthoracic echo, and along with the mixed venous oxygen saturation, we need to assess, central venous oxygen saturation, we can implement pulse contour analysis to assess the response. And if they further go for right heart failure or a low cardiac output stage becomes more and more complex, then pulmonary artery catheter has its role here in these kind of patients. And valvular defects, coronary artery disease, pulmonary heart, complex patients, pulmonary artery catheters play a major role in assessing the hemodynamic monitoring. So how do we, either you can be a reactive person or a proactive person to assess and to monitor the hemodynamic changes in the perioperative period and in the critically ill patients, and also extend into the postoperative monitoring of patients who have hemodynamic instability. A reactive person would be to correct the changes which is happening, like to correct the hypotension, to correct the tachycardias, and give fluids when you suspect hypovolemia secondary to pulse pressure changes, and promptly react or identify the cardiac output. Whereas proactive management would be maintain an adequate arterial blood pressure with a MAP of more than 65 to maximize the stroke volume, and to maintain the pulse pressure variation between the 12 to 14% range, and using invasive hemodynamic monitoring to maintain the cardiac index of around 4.5 liters per minute per meter square and maintain a central venous saturations of more than 65. This has to be implemented during the perioperative period, postoperative period, and as well as in all critically ill patients. Thank you.
Rajesh, sir.
Thank you, Aarthi. Thank you. Thanks a lot for the elaborate lecture. We have some questions, Aarthi.
Yes, sir.
So what is the role of PAC over transesophageal echo? Is it reliable for cardiac output monitoring? Which one is reliable? Whether pulmonary artery catheter or cardiac output? This thing, transesophageal echo.
Sir, it is not the technique which we actually compare the reliability. It is more depending upon the clinical scenario of the patients. When you have a patient who is intubated and who have a complications, who know where we have to monitor the hemodynamic status, I would first start off with the, when there is an available transesophageal echo, then I would first start off with the transesophageal echo. That will be less invasive compared to the pulmonary artery catheters. Pulmonary artery catheters are gold standard, but then it has more of observed variation and a lot of technical difficulties to assess the hemodynamic response. Whereas transesophageal echo would be a bedside assessment, which would give a more reliable information. So it is always more of a patient-centered rather than the monitored-centered.
Arterial blood pressure versus non-invasive blood pressure in ICU, which one will give you accurate blood pressure monitoring? If you go for invasive lines, how long you have to keep the lines, and whether it is ultrasound guided arterial line placement or
Okay, so coming to critically ill patients, comparing non-invasive blood pressures and invasive blood pressures, non-invasive blood pressures always doesn't really work well in extremes of blood pressure changes. In a low blood pressure situation, it overestimates the blood pressure. In a high hypertensive patient, it underestimates the blood pressure. So invasive arterial monitoring is indicated in extremes of blood pressure changes, and ultrasound is mandated nowadays to utilize and to avoid complications when you go for a insertion of an arterial access. And how long, there is no specific guidelines of how long we need to leave the catheter in. It is how we maintain the catheter access, and daily monitoring and daily inspection of the insertion site is mandatory. Once you suspect an infection, ongoing infection, or signs, earlier signs of thrombophlebitis or earlier signs of arterial inflammation, then that is when we have to remove the arterial access immediately.
Can you tell about mini fluid challenge? You mentioned again and again about mini fluid challenge. What is it?
So there are a lot of studies and guidelines which ranges normally fluid challenges we tend to give between 250 to 500 mL of volumes. So there are certain guidelines now evolving about mini fluid challenges less than 200 mL. For example, 100 mL to 150 mL, where in patients where we expect them to develop pulmonary edema. For example, in patients who have vascular leak syndrome, in patients with ARDS, where risk of volume overload is high, that's when they advise a mini fluid challenge of 100 to 150 mL of fluid boluses given over 5 to 10 minutes period, and then the pulse pressure variation or stroke volume variation is assessed at the end of the infusion to avoid volume overload.
Thank you. Thanks a lot, Aarthi. Thanks for your nice explanation and the lecture. Thank you. We'll move ahead with the next lecture.
Thank you, sir.
So the next lecture is on hemodynamic monitoring, which is non-invasive methodology. And speaker will be Dr. Prateema, who is a ICU coordinator and senior consultant in critical care medicine from Apollo Speciality Hospital, OMR, Chennai. Looking at her profile and the degree what she had got itself speaks a lot that how much she is passionate towards critical care medicine. After clearing DNB, she had got both IDCCM and IFCCM, which are from ISCCM degrees. and she had also cleared her European diplomate in intensive care, EDIC, and she is teacher for various critical care courses and certified simulation trainer, and she is also ATLS provider and instructor for ACLS and BLS, lot of paper presentations and lot of CMEs and conferences attended as faculties. And she had conducted a workshop in hemodynamic monitoring long back in 2016 in IFCCM. And she's the right person to talk about hemodynamic monitoring, non-invasive methodology. Over to you, Dr. Prateema.
Sir, good morning. Good morning, everybody. Happy to be here. Thank you for having me here. It's a Sunday. It is really surprising, like so many people has joined. So without much delay, I would like to go into the presentation. So am I audible, sir? Is the slides moving?
Yes, ma'am. Yes, ma'am.
Okay. So thank you for the nice introduction. Yes, I'm passionate towards critical care, and I'm basically an anesthetist. So both together. So today, I think Dr. Aarthi had given a very comprehensive lecture about hemodynamic monitoring itself. And most of my slides or talk will be overlap. Anyway, I'll keep it less invasive as possible. Okay. So what is hemodynamic monitoring? Is it really necessary? What are we monitoring? So we need to look at the patient. Hemo is blood, dynamic is movement. So we need to know how the blood is getting moved into the patient, basically the circulation. And what is our role? We are there to give oxygen to the patient and make sure oxygen is all perfused. It is reaching the target cells and it is getting used properly. So this is the basic thing what we do if we talk in English about hemodynamic monitoring. So there are various variables. We really don't know. We are giving oxygen through the lungs and the tissues are elsewhere. It is the duty of the heart to pump properly. There is a pump or a motor, which is the heart. There are many tubes. It is basic plumbing. So the arteries or the tubes, and there is a tank. So the venous capacitance or all the veins, we call it a tank because they are reservoirs. So is the pump working well? Is the tubes working well? Is the tank getting filled, or is it half full? So this is what the whole hemodynamic monitoring is about. So if you look at just a glance, it is going to be a static. We don't know whether it is moving, it is in a circulation properly. So as Dr. Aarthi had comprehensively talked about all the methods of hemodynamic monitoring. So basically we use all these monitors only to see whether the blood is getting appropriately perfused and is the tissues getting proper oxygen, and vice versa. If the tissues are clearing off the toxic materials, is it coming back to the heart, going to the lungs, and is the blood getting purified? So this is what we need to know in a patient. So a patient comes to ICU when the patient is sick. In anesthesia, it need not be, but we need to always have a look at the heart and the working of the heart. So oxygen delivery, basically, as I told you. So is the delivery very good? Is the tissue oxygenation very efficient? So what we look into three different parts. So one is the hemoglobin, which carries oxygen. One is the cardiac output, which keeps the circulation going on. And other is the arterial oxygen saturation. How much is the oxygen climbing into the blood, climbing into the RBCs and sitting there for the voyage. So all these three components are very, very important. And if we break them into small parts, okay, we know the hemoglobin, we can just measure it once every day, that is okay. Or if the patient is bleeding, we can measure it every 8th hourly. We don't need to keep on monitoring or see it every minute. Yes, and we have oxygen saturation monitors like pulse oximeter. We just plug it in and put the clip around the patient's finger. So oxygen monitor is continuously, oxygen saturation is continuously monitored. So what we have to look into continuously is the cardiac output, because the heart is receiving blood pumping. Okay, is it working very well? So break it into even smaller pieces. Okay, cardiac output, how do we monitor? We need to look into two things: stroke volume into heart rate. And stroke volume is the one shot which the heart gives at one go. So how many times does it beat and how many times it is hitting a sixer is what we need to look. So stroke volume and heart rate. So heart rate, we know it will be in the ECG and it is a continuous monitoring. Yes, okay. So stroke volume, how much the heart is receiving. So what is pushed into the heart is the preload. So how do we monitor that? And is the pump or the motor function good? As I said, it is called in medical language ionotropy. And how much of the load is pushed against a resistance? It is afterload. What is the peripheral resistance? Is the artery is very stiff, or is the pressures on the artery side very stiff? Is there a vasoconstriction? Is the heart working against a resistance? Is what we have to see. So all these things put together is the hemodynamic monitoring. So what we have to look at is mainly the stroke volume, and broken into pieces, we have to look into the preload, ionotrophy, and the afterload. So this is basically by clinical basic monitoring, advanced monitoring, and cardiac output monitoring. So clinical, we know how we monitor. We'll just go through everything. So what is the goal of monitor? What do you want to see? So assure the adequacy of perfusion. We are standing in the bedside. We need monitors to look into the patient. So monitors are a communication between the patient and us. So we need to look into the adequacy of perfusion. Is the blood getting perfused well? And if there is any inadequacy, the monitors need to tell us or alert us in an early way so that we can act upon it and catch and prevent further deterioration. And if we are alerted, we are giving some intervention. So assess and we intervene. Okay, we are intervening. How much should we intervene? Is there any measure? That is a titration. And okay, there are different organ system dysfunctions. Can we differentiate? These are the things which the monitors need to tell us. This is what we expect from the monitors, because we can always stand and look into the patient's numbers, but we need the monitors to tell us what's happening. Is there any issue? Immediately, the monitor has to alert us. And in case we are intervening, we need to know how much to titrate. Should we increase? Should we decrease? Can we give fluids? Should we give vasopressors? All these things needs to have numbers so that it is all in a uniform basis. Maybe I feel that I should give fluid to a patient, and my colleague feels that it is like patient is fluid filled, so he needs to dilute the patient. So what is the number which we need to do? And it is not one single number, it is a trend. That is what the monitors tell us. So what is a physiological truth? So telling the total secret of hemodynamic monitoring, there is nothing called a normal cardiac output, because it is not like one size. We are, the clothes are different. It is not like one size fits all. So the cardiac output is changing, and absolute values cannot be taken as foolproof. So either it is adequate to meet the metabolic demands, or it is inadequate to meet the metabolic demands. So there is a demand from the body. If the patient is sick, if the patient is septic, the demand goes up. Is the cardiac output adequate to match the demand? So supply and demand match is what is very important. There is nothing called a normal cardiac output. We call sometimes the cardiac output normal because we need a baseline. So we need to know whether it is increasing or decreasing to find out whether the heart is working very well. So we need to monitor. Yes, we have invasive, non-invasive. Invasive had been talked in length and in very comprehensive way. So non-invasive, what do we do? Basically, we do a non-invasive monitoring when we start with the clinical examination and history. Yes, we start monitoring the patient. We look at the heart rate, pulse. How is the patient? Is the patient warm, cold, clammy? We have a lot of fancy terms. So basically, there are 3 windows to see whether the patient is adequately perfused in a clinical examination. One is the mental status. Is the patient having an altered sensorium? If the patient is in shock or the cardiac output is not good, the patient is going to be drowsy. So that is one window. Second window is the urine output good? So urine output falls after some time, after the compensatory mechanisms fall. Then a third window is the skin. So we touch the patient, see whether the patient is cold, or sometimes in a shock, patient can be warm, but the sensorium can be low. So all the 3 parameters or the 3 windows are what we do look into when we do the clinical examination. So there starts the monitoring, and it is non-invasive. So when we look at the patient, we need to know, is there a problem? Okay, blood pressure is normal, but if the blood pressure is normal, we cannot rule out a shock because there can be some compensatory mechanism going on. That's why we need to look at the heart rate. If the patient tachycardic sweating is there can be a vasoconstriction, we don't know. So the body is trying to keep the blood pressure normal. So the blood pressure, if it is normal, cannot rule out a shock. And we need to look at the end organ function. As I told you, there are 3 windows, including the skin, then the mental state and urinary output. Then there are tests which we do immediately after the clinical examination, which is the blood gas analysis. If you look at the pH and if it is acidotic and if there is hypoxemia and if there is increased lactate, we now know that the patient is not getting adequately perfused. So there stands the next level of clinical examination. So this is one case where there is mottling. So you can see that the tissue, the skin is inadequately perfused. So the patient is cold and the skin looks very unhealthy. And we can see this thing as mottling and patient is surely in shock. In this patient, if the blood pressure is normal, we have to look at the heart rate. If he is tachycardic, if he is drowsy, there is less urine output, then we can see there is edema, but fluid is in the wrong space. So definitely the patient is in shock. So how do we measure the blood pressure? So non-invasive automated devices and invasive measurements. We know that we went through the arterial line in detail. So non-invasive, I just want to touch upon the simple basics because this is the first thing that we take in our hand before starting the patient on any other monitoring. So we need to know what is the right size of the cuff. So cuff width is very, very important. It should be at least 40% of the circumference of the arm. If it is very wide, if the patient is thin and it is a big cuff, it is going to underestimate. It will show a low BP. And if it is too narrow, it is going to show a overestimate. Even if the patient has a normal blood pressure. I'm talking about a patient just for a health check. And even if this is so faulty, imagine about patients who are sick. So width of the bladder should be 2/3 of the upper arm and length should be at least encircling 80% of the arm. So we must make sure it is not crossing the antecubital space and it should be at least 2.5 centimeter above the antecubital space. This is a proper fit of a blood pressure cuff. So non-invasive, it is underread at high pressures, overread at low pressures, less accurate during arrhythmias. So it is a way in which it measures the oscillatory parameter. The blood pressure has a pulse and the pulse over the brachial artery is just monitored by the sensor in the cuff. And the oscillatory method, it shows, it just calculates where the oscillation is higher, lower, it makes a calculation and gives us a reading. But if there is a arrhythmia, imagine the patient is in an atrial fibrillation. The patient will not be having a regular heart rate. So there can be changes and there can be a faulty blood pressure. So invasive, I know already we had talked a lot about the invasive monitoring. So we'll just go through the further things. So exactly what do we want to know? Okay, we have just checked the patient, taken a history, clinical examination is done, which we do it simultaneously. We don't do it in sequence because the patient is sick. So we want to know what is the issue. Is there a hypotension? Patient is in a shock. How severe is the shock? So what do? We immediately give fluids, always ABCD. So we take care of the airway, breathing. Then we just place an IV line for a circulation. And we just assess the patient's disability, GCS, sugar, and we check the temperature, touch the peripheries. So that is what we do in a clinical examination. When we just do it, this is what goes in our mind. Should we give fluid? Is the patient going to respond to fluid? How do we know? We do not know without any monitoring. And will the patient tolerate fluid? Okay, the patient is breathless or the patient is in shock. Maybe it is a cardiogenic shock. We don't know. If we give fluids, maybe it is a bolus of 250 ml, more than 250 ml. So usually we just rush in 500 ml. Will the patient tolerate fluid? That is what we need to think about before doing anything. So is it going to be fluids or inodrops? I'm going to be thinking that I have to be giving fluids for hypotension. My colleague would think that it's better to start noradrenal or a dopamine drip. So what should we do? This is what will be running. These are the questions which will be running in our mind. So how do we decide on it. So just going to the basics, just deviating away from our clinical scenario. So what are we thinking about in subconscious level? So is the cardiac output adequate? So as I told, there is no cardiac output, normal cardiac output. It is going to be whether adequate or not. So what do we have to know? Is the blood flow adequate to meet the metabolic demands? So okay, if it is not, what is the pump function? How is the heart? And is there adequate intravascular volume? Is the preload good in the other sense? And driving pressure for the venous, is the tank filled up? Is there any increased afterload? So this is what we need to know. To know about that, we should know about the left and right ventricular function, literally the heart function. And particularly, we are more worried always about the left ventricular ejection fraction. Then we need to know whether the patient, if the patient is intubated or not, or spontaneously breathing, we need to know when the patient is breathing, is there a change in the blood pressure or the hemodynamics? And what is the preload? Is the tank filled well? Is the patient having a good volume, or is he losing? Or if you give a fluid challenge, is it going to be responding well? So this is what we need to know. So two main things: how to give fluid. Okay, we decide whatever it is. We always decide to give a small bolus like 250 ml. It is not going to cause any deterioration. Okay, how do we give fluid? Is it going to be a literal fluid bolus? Sometimes it is. It can be done with a passive leg raise. So as you can see in the picture, the patient is in a head-up position, and this is what is done in a passive leg raising. The patient is made flat, and the leg side is lifted. So this is like an auto transfusion. So instead of giving a fluid bolus from outside, this patient is given a passive leg rise. Okay, so bolus goes into the heart from the lower part of the body. Whatever pooling of blood is there, it is just given as an auto transfusion. And we also look at the heart-lung interactions. If the patient is ventilated or spontaneously breathing, if the patient is taking a deep breath, what is happening to the blood pressure? So this is what we decide to do. Okay, we can give fluid, we can work on it, but how to check the response? So that is where we need the hemodynamic monitoring. So invasive and non-invasive. So we are standing in the bedside. So how do we know what is the response? So there is something called a pulse contour analysis. This is one pulse which is seen in the arterial waveform. So I'm not talking about the invasive. I just want to go into the basics and tell you the principle of what we are thinking and from where we are calculating the hemodynamic monitoring values, interpreting values. So, so there is a systolic pressure, and there is a dicrotic notch, and there is a diastolic pressure. So this is how a pulse looks like. So this is a systolic area. This is where the whole systolic pressure acts and the systole ends. So systolic length. Okay, and the systolic area is related to the preload and the contractility. How efficiently the heart can contract is what is decided by the systolic area. And diastolic area, we know that it accounts for the afterload. We can calculate that. And there is a mean arterial pressure, which is calculated with the systolic and diastolic pressure, and that is inversely proportional to the compliance. So compliance, if you give volume, how much pressure is going to increase? If with a little volume, the pressure is going to be very high, then it is bad. Should be proportional. Or if you give so much volume and there is only little increase in pressure, then that is also not going to help us. So we need to know the mean arterial pressure. So this is the pulse contour analysis, and this is what all the monitors will look into and give a calculation. So we are, I can talk about me personally. I'm not a very active person. I might be lazy. I just want to just look into only the numbers and just know, okay, the patient is okay or not, just give blood or not, because I have too many patients to see. I cannot sit and calculate, and I'm bad in maths also. So what do I do? So this is pulse contour analysis is one principle. Next is stroke volume variation. Every time we give a breath, or if we give a big intrathoracic volume, the lungs expand and blood is squeezed out of the chest into the other parts of the body. So if the volume is very low, then it is going to be a very big change, and it will be an exaggerated response. So what do we do about it? So we need to know if the blood level is very low. If we give a push, it is going to be very high. And when the it returns to a normal volume in the intrathoracic, when that is the expiration, then the blood comes to the normal level. It falls to the baseline. So within the squeeze and the let out of the pressure, how much is the volume changing? So that is the stroke volume variation. So if it is very exaggerated, then there is going to be more response because it has much space to do that, and we have space to fill the patient. That's what is interpreted. So there will be an exaggerated drop in the stroke volume, and that is what we call the stroke volume variation. So again, this is literally the basic of all the hemodynamic monitoring. So I'm just repeating it. Okay, so we are thinking about giving a fluid bolus. The patient is the patient responsive? So if we give a small bolus, we are giving fluid bolus, is the stroke volume increasing proportionately? Then that means that the patient has a good fluid responsiveness. But if we give a fluid response and the systolic volume is the stroke volume is not increasing very well, then that means that compliance is bad, and if we keep on giving, we are going to flood the lungs also, causing more pulmonary edema. So we need to back off. So we don't know. With hemodynamic monitoring, we will know whether the patient is in this part of the curve or this part of the curve. So arterial line, we know it is a continuous monitoring, and we can find all the traces. But we also did talk about, Dr.Aarthi did mention all these static and dynamic parameters. I don't think I have to touch upon it again. So it is just the pulse pressure variation. So dynamic, static, it is just eyeballing, but dynamic means if you are giving a preload, if you are giving a small bolus, how much it is changing is what is the dynamic change. So we need to look at how much it is going to change, if the patient is going to tolerate or not tolerate. So PA catheter, it is a very big timeline, and 1970 it was found out. It was like very exciting. There are many studies which said PA catheters are good. Then slowly they started saying that they might be bad, and now it is like from 2005 after the Pacman trial, there is less popularity for the PA catheter. So it is slowly coming down. So beyond the PA catheter, what can we do? Before we were only dependent on the PA catheters. And we know that there was from Dr. Aarthi's lecture, we just heard about the cardiac output monitoring and how it was done. Now, if there is no PA catheter, how are we going to go about? So there are other invasive monitoring like LITCO, PITCO, where there is a central and arterial line put in, and slowly it became minimally invasive. Now, in this talk, I just want to just touch upon all the non-invasive hemodynamic monitoring and with the principles. I don't want to sit and talk about each and everything in detail because it is like fast changing. Every year there are new equipments coming. So it is better if we know only the principles and know how to interpret the values just with basic knowledge. So echocardiography, this is going to be there for many years together. Either it is transthoracic or transesophageal. There is also a Doppler ultrasound, which we'll be talking about it. Then pulse wave from analysis, PITCO, LITCO are minimally invasive. Flow track is also the same. It has arterial, it needs an arterial line in situ. And we also have electric impedance cardiography. And we have other NICO, which uses the indirect FIC principle, and bioreactants and NextFin. So echocardiography, I'm sure you all have seen bedside echocardiographic machine, ultrasound machines with basically an echo probe. So it has made our life easier. So we can, just to know the basics, this is a probe which has a metal outer casing, and this is a power cable that goes to the machine. This is on the patient side. This is called the plastic nose. So it has a rubber coating, and it has this is the most important part of the probe. It's a piezoelectric crystal. Okay, so this is used to monitor the patient. So the principle is that when there is a movement that can, which is the sound, ultrasound is changed to a movement of the small crystals, and these crystals change and show as an electric signal. So this is what is seen in the screen of the ultrasound machine. So what are the echo windows? We have this parasternal apical and subcostal views. Sorry about the numbering. This is parasternal, this is apical, and this is subcostal. So we divide the heart into short axis plane and long axis, and in apical we can see the 4-chamber view. So just to put all these into one slide, this is a schematic diagram. This is how the probe is placed in the left parasternal region. The pointer will be pointing towards the right shoulder. This is a cardiac probe, and cardiac probe should be properly placed over the left intercostal space. This is if placed with a pointer towards the right shoulder, it is going to show the parasternal long axis view. So it is very, very important. We can see that this is the right ventricle, this is the left ventricle, this is the left atrium. So left atrium, left ventricle, this is the mitral valve. This is the right ventricle outlet actually. Yes, we can see the aorta here and the aortic valve. So this is a cross section. Here we can see that there is a aorta, descending aorta. So this gives us the ejection fraction. We can see how much LVOT we can measure. We can measure how much of a volume time integral. These are all fancy terms, but it is basically to calculate the cardiac output. So we all know that left ventricle will contract to eject blood through this. So if we measure the velocity and how much the aortic valve is opening and how much of blood is ejected through the aorta, we can find out the cardiac output. It is literally in proper English, only that we are measuring in this view. And we can see the contractility. This is a short axis view. The same probe, same place. If you just rotate to 90 degree and the probe marker is towards the left shoulder, then we will get an image like this. So this is a cross section of a left ventricle. We can see the muscle mass, and we can also see the right ventricle. And if the right ventricle pressure is very high, then we can see that it can be pressing over the left ventricle. So this is a normal patient, a normal heart, so that we don't see any different or a pathological feature. So this is how a parasternal short axis is seen. In this, we can see how the papillary muscles are there, how the heart is contracting. And this is the 4-chamber view. We can see that it is in the apex, and the pointer is towards the left shoulder again. So we can see the right ventricle, left ventricle, right atrium, and left atrium. And we can just rotate, do some adjustments, and see descending aorta and pulmonary veins also. So this is a subcostal view. This is also very important because we can see the liver and the right ventricle. If there is any pericardial effusion, cardiac tamponade, we can see through this. So if there is a cardiogenic shock, if the pump is not, this is basically looking at the pump. Is the heart the reason for the hypotension? If the LV ejection fraction is low, we can see whether there is an obstructive shock. If there is a pericardial tamponade, we can just put the probe on the machine. No fancy extra monitors are required. Just with this echo probe, we can monitor how much of ejection fraction the left ventricle is having, or is there any disturbance to the heart, and is it pumping very well. So this is a very, very famous thing we do in our ICU bedside. We just put the probe in the subcostal region and with the probe marker towards the head, towards the chin. So there we can see that there is an inferior vena cava, the liver. We can also see the hepatic vein, inferior vena cava, right atrium. If we see the blood vessel connected to the right atrium, then it is inferior vena cava. Sometimes it is confused with the aorta also. So this is basically monitoring the fluid level, how the volume in the patient. If the IVC collapse very well during the breathing, deep breathing, then we know that the patient can accommodate more fluids. If we see something like this and the IVC is full, then we must think twice before giving the fluid. And next to this, we always do a lung ultrasound to see for B lines. So I have not put any images for a B lines, but if there are B lines, we do not give fluids. We just make sure the patient is not overloaded. So if the IVC is full, but the patient's lung ultrasound is better and it doesn't have B lines, which is evidence of increased fluid overload, then we can give more fluids. So that is how we use the echo probe at the bedside. So then comes the TTE. Here we have all the modes, 2D, M mode, and Doppler, which can be used, and echo contrast 3D images also can be seen in this. And all the LV dimensions we can measure manually or automatically. This is basically like a Ryle's tube or a endoscopy. We just put the probe into the esophagus, and we see from the back side of the heart. And with calculations there and with measurements, it just gives the cardiac output and other hemodynamic parameters. But the limitations is we need a good window. It cannot be kept there for time immemorial. We cannot just continuously monitor. We can just keep for some time till the surgery is over and take it off. So this is what the TEE. We get the transgastric views. It is very close to the heart and aorta. Better images are seen real time. We can see that how the heart is getting pumped. Is there any infective endocarditis changes? Is there any vegetations at the wall? This is basically how the health of the heart is, how good it is beating, or is it able to pump adequate blood. So it is invasive, it needs sedation, and only a skilled operator can do. So it is not like we can, it cannot be done by everybody as the transthoracic echo. So then comes, these two are echocardio. Then we look at the Doppler. Doppler is always the flow of blood. So in the aorta, how it flows, how is the blood flow? That is going to measure the cardiac output. So stroke volume is what we decided to measure. So stroke volume into heart rate is the cardiac output. So in this Doppler, we can measure the outflow of the heart. Everywhere, hemodynamic monitoring, all the monitors are concentrated at the aortic root. So that is where they take the cross-sectional area, which is measured along with the movement of blood and the time in which it moves, it takes to move, and SV is calculated. So this is what I told you, stroke volume and heart rate, how much time it is there, and it gives us cardiac output directly. We can get a number on a screen. So it is like, it is not going to be, there is no need for a picture monitor continuous, it is lesser cost, so it is going to be there. So this is how it looks, and this is a monitor, and we can see the Doppler flow, how much it is, and when the trace is done and we enter the heart rate, it is also measuring the heart rate, and stroke volume is calculated, we can see the cardiac output given there. So with the cardiac output, it is not one value, we can see the trend, how it is. We can also see in the graph how it is changing with the fluid bolus, or how the patient is responding to anesthesia or any medication in that part of discussion. Okay, so this is how it looks. It is a USCOM transducer. So USCOM is ultrasonic cardiac output monitoring. So the transducer is it's non-invasive. It's a non-imaging Doppler. It is not going to image. It is just a waveform which is seen. The flow velocity is measured from the aortic root, and we have to keep it in the suprasternal notch. And there will be a sharp, well-defined waveform in the monitor, and that is the cross-sectional values predicted or measured by the transducer, and the cardiac output is calculated along with the cross-sectional area, flow, and the heart rate. So that is how it gives us a value. So next is TICO. This is a trans-esophageal cardiac output monitor. So this is ultrasonic, which we saw previous is the ultrasonic cardiac output monitor. This is trans-esophageal cardiac output monitor. This is also a non-imaging. So we are not going to see any images from the mid-esophagus. The probe is placed in the mid-esophagus. In TEE, where we put the the trans-esophageal probe into the esophagus, we see the images. But in this, we see only the Doppler. And it is a similar way as the USCOM is. This is minimally invasive. If we think Ryle's tube or endoscopy is invasive, then it is invasive. But this is it can be left there for some time, and we can see whether the patient is having a hypovolemia, or what is the percentage of descending aorta flow changes in certain conditions, which when spinal is given, this can be used in the operation theater when there is a high risk surgery. So when we give fluid, when we look at the cardiac contractility, what is the change? So we can see a lot of changes, and only graph is given. We do not see any images. So this is how it is seen. So the probe, we can see it is placed in the patient esophagus. It is looking at the heart. We are not going to get any images. We are going to get only Doppler graphs. So this is there. And we can see that again, the cardiac output is monitored. We can see that the change in how it reflects on the blood flow. Every time a blood crosses the aortic valve, the root of the aortic valve, it is seen like this. So lot of variations and parameters are seen. So flow time is very, very important. The flow time is measured and it is the FTC which is important. And this FTC is corrected as per and adjusted to the heart rate of 60 beats per minute. So this is how it looks. How are we going to interpret? This is going to be the baseline. If we give fluid and if the stroke diastole increases, then it is going to be favorable response. Yes, everything increases. We can see the flow FTC also getting increased. And we see the graph. So for this, the diagnosis is possible hypovolemia. So we give fluid and there is a positive fluid response. But in this, we can see that the flow is not very good. So the stroke volume is very, very low and it's blunted. So when we start ionodrop, we can see that the blunting effect is gone and the flow is improved. This is how we see images on the monitor. So this is also a non-invasive cardiac output monitoring. This uses the fixed principle. In this, the indicator is carbon dioxide. So exhaled CO2. So as we see, we can put this probe on the ventilatory circuit and we can see something like this. So carbon dioxide, how it changes, what is the cardiac output is all measured and given as a number. So fixed principle, the gas leaving or entering the lung depends on the blood flow through the lungs and the arteriovenous difference. So we can kind of look at the monitor and find out how it is. And this is the capnostat, the carbon dioxide sensor. And this is the rebreathing valve. So we know that there is a Nico loop and this is adjusted. So we have a monitor which is fit here and it has a cable which goes to the monitor and numbers are displayed there. Nico is non-invasive cardiac output monitoring. So there are calculations done in this partial rebreathing system and displayed as numbers. So then we go for the electrical impedance. So we know that there is interaction between heart and lung. When there is increased intrathoracic volume, when there is an inspiration, the blood flow changes. And when there is exhalation, the blood flow changes. So there are sensors put on the chest and it is all monitored with the impedance, how it is transmitting current and everything is put over the monitor. So this is impedance versus bioreactance. It is not very sensitive. It is not widely used. It is just in the trial phase. So we just need to know about it. So it is very difficult to set up and every small noise causes an issue and it is not foolproof. So that's why I just mentioned it. We need to know what it is, but it is non-invasive, yes, but it is not very trustworthy as of now. And this is one of the latest thing which we might see in our OT soon. So this is a non-invasive monitor, CNAP we call it. This is it is like a blood pressure cuff over the fingers. So we can see that there is continuous monitoring of arterial pulses and with all the variations, the pulse contour analysis, everything put together, there is a multiple control mechanism. With this, there are a lot of variables or parameters displayed on the monitor. So this is coming up soon. I think in the intraoperative monitoring, this is going to be very popular. But in ICU patients, it is still under study and it is not advised to use this in patients who are very sick and in severe shock states. So evidence, yes, we have a lot of studies which have been done comparing cardiac output and blood volumes in by ultrasound dilution and transpulmonary thermodilution. All these methods have been compared and there have been cross comparisons with LITCO, PITCO, flow track, PAC catheters. There are a lot of pitfalls in hemodynamic monitoring. No, we cannot take one hemodynamic monitoring and say that it is enough for the patient. One variable is not enough for the patient. So there have been a lot of pitfalls which have been studied and slowly the evidence of minimally invasive is helping in perioperative setting, yes, but in ICU still studies are going on and all these ODM, transpulmonary dilution, which looks very, very promising. And ODM is esophageal, this Doppler monitor. But it needs further evaluation in sepsis or any other forms of shock. It is not going to help very much. Still, invasive holds the first place and the priority because nobody is willing to just look at the non-invasive and say that things are right because it is life or death situation in the ICU. So there had been a lot of protocols, flow charts, but whatever it is, it needs more study. There are not much of an outcome benefits. And even with the protocolized algorithms, we can see that the outcome benefits are not so high. And intensivists, by their personal choice, they are looking into at least minimally invasive cardiac monitoring. They are not a totally, it is like put on autopilot mode, thinking that non-invasive is good. But in OTs, where the patient is going for a high-risk surgery, the patient is not very sick preoperatively, then there are, the surgeons are very happy if the anesthetists use the non-invasive methods. So what next? So we have all these things, invasive, non-invasive put together. So what next? So there are many modalities available which are non-invasive or minimally invasive. Challenging the PA catheter is still a big issue because even now we know that cardiac surgeons are comfortable in putting a PA catheter and watching it, and can use them as initial modality in appropriate patients. Yes, we know we have to be very selective which hemodynamic monitor to use for which patient is very, very important. And if there are not much of a response, then we can change over to more invasive PA catheter. And as I already said, esophageal Doppler monitor is gaining popularity in Western countries. It is being used in almost all the patients undergoing high-risk surgeries. So limitations are there. We cannot differentiate between the pulmonary edema. Yes, we always look at the cardiac output. Yes, how is changing? Yes, but is the lungs getting wet is what we need to think about it. The tolerance is not much. And if there is a septic shock, it is going to hurt the patient again. We don't know. There can be non-cardiogenic pulmonary edema also. ARDS patients, it's quite tricky. And if it is combined with goal-directed intra-fluid management, it reduces the pre-op mortality. But more studies are still avoided. So points to be noted in everything in hemodynamic monitoring as a whole. Tachycardia is never a good thing. We cannot just avoid tachycardia, and hypotension is not always pathological. And there is no normal cardiac output. CVP is elevated only elevated in disease. Higher mortality was shown in patients with right ventricle dysfunction. We are always somehow fixed with the left ventricle function only, but we need to have a very good idea, and we must also know that right ventricular mortality, dysfunction mortality is higher than the left ventricle. So we have to have more devices looking at right ventricle also. So to summarize, no monitoring device, even if it is simple or complex, or it is invasive or non-invasive, it is going to be very accurate or precise. So whatever it is, it cannot be improving the outcome. It is the judgment and the treatment, and the doctor or the medical treating team makes the difference in improving the outcome, because it should be judiciously used. Just because it is available, we cannot put a esophageal Doppler monitor on all the patients and take whatever numbers are there as a foolproof. And if it is going to be a PA catheter, we must have very clear protocol for using that, and it cannot be just put in auto mode. There has to be a bedside personalized care that is going to improve outcome, and not only the gadgets. So yes, after a long lecture, after talking about hemodynamic monitoring, it is very sad to say, but hemodynamic monitors are not the only way to improve patients. It is just a guide, and judicious use of the hemodynamic monitors and the knowledge, proper knowledge and interpretation is going to help the patient more than the monitor itself. Thank you.
Thank you, Madam Rajesh.
Thank you very much, Madam, for that excellent lecture, and a lot of newer advances you have shared with us. And the take-home message was very, very nice, that what you have delivered. Some few questions, Madam.
Yes.
Non-invasive blood pressure monitoring in morbidly obese patient Where if you don't have a proper cuff size, so how to tackle that situation?
In obese patients, it is very important. We can use a thigh cuffs. Thigh cuffs are available. We have used on patients, but if it is not giving a good seal or what I had told already, 80%, if it is not covering, then we have to go in for an intra-arterial blood pressure monitoring. It depends on how sick the patient is. Just the patient came for observation, and we cannot be doing invasive arterial monitoring. And manual blood pressure monitoring is also very important. So we need to know the trend. Even if we have a NIBP, we have to do a manual to see whether it is correlating with the NIBP of the obese patients.
Perfusion index in hemodynamic monitoring, the perfusion index in pulse oximetry. Perfusion index.
Perfusion index. Okay, so it is also under study only, sir, because if there is peripheral vasoconstriction, in the pulse oximeter, if we look at the peripheral perfusion index, is it going to correlate? And in old patient, particularly when there is vasoconstriction, and in ICUs, we know the temperature is very cold and there is vasoconstriction even due to the environmental change. So everything put together, we cannot use perfusion index as foolproof. It is also just under study. It is not regularly used in ICUs or OTs.
Non-invasive cardiac output monitoring, which one will be most ideal technique at current scenario? Non-invasive cardiac output.
It depends on the scenarios. As Dr. Aarthi also said, which patient, which monitor to use for which patient. So in particularly OTs, this esophageal Doppler monitoring is very, very popular nowadays. So they just place it so that they can know whether the fluid is given, because we do not have access to the chest. When they are doing a big hepatectomy or they are just doing a big laparotomy, we cannot cross, the barrier will be always there between the anesthetist and surgeon. So you cannot always cross and get the echo done. So if there is going to be, and transesophageal echo also cannot be placed for a longer time. But this is like a small raised tube. So I know it is a bit costly, but it is worth the cost. So if they keep the esophageal monitor in place, the Doppler gives us a lot of variations and the trend when we use the fluid. Only thing is we will be not knowing about how much the lung can tolerate the fluid. So if it is a multi-hour surgery, if it is going to be more than 8 hours, the patient, will be giving a lot of fluids. And particularly in liver surgeries, the surgeons might want us to just go low on the fluid thing also. So we use vasopressors. But in between this fluids and diuresis, we don't know how much the lung is getting affected. So only one problem. Otherwise, if the patient's lung is better, there is no pulmonary edema feature, if the heart is good, then it is not going to be a very big problem using esophageal monitor.
Thank you, madam. Thanks a lot. Thanks a lot.
Thank you so much.
Thank you, madam. We'll move on to the next presentation. Central venous cannulation by Dr.Sasi Mayukha, who is a consultant critical care physician from Vijaya Hospital, Chennai. She is also highly passionate towards critical care medicine, because I know her from her postgraduate days when she joined post-graduation in anesthesiology. The first thing what she told us is, I am going to become an intensivist, and right now she is an intensivist. Welcome, Sasi Mayukha. You can deliver your.
Thank you, sir.
You can share your slides.
Yes, sir. Good afternoon, everyone. Today I'm going to talk to you about central venous insertion. The few things I'm going to talk about is the equipment which will be required, what are the sterile precautions which will be needed, and the technique of insertion. So now moving on to the topic, as the previous presenters have already told about central venous line, the importance of CVP measurement, I'll brush through the first few slides and then we'll go on to the demo. So if you see why central or peripheral route, so usually the selection depends upon the type of fluid, the medications to be administered, and the length of time access. Because this is very important in an ICU setup when the patient comes, when you have to give a lot of inotropic support, when you need dialysis, you need a central axis than a peripheral route. So the indications for short term will be fluids, electrolyte administration, high volume of blood transfusions, to monitor the central venous pressure, and to give chemotherapy drugs, and for giving TPN. So what are the types of central venous catheters which are available? There are non-tunnel central catheters, tunnel central catheters, peripherally inserted central catheters, and implantable ports. The most common which we use in an ICU setup or an OT setup is the non-tunnel central catheters. What are the three access sites which are available? It is the internal jugular vein, the subclavian vein, or the femoral vein. So how do we decide if a patient comes whether to use the internal jugular, the subclavian, or the femoral vein? All of these have pros and cons. All of them have a lot of advantages and disadvantages. So depending upon each patient, we have to decide whether we go for an IJV cannulation or for a femoral cannulation. What are the equipments required for the central line insertion? You need a sterile tray with sterile instruments, gown and drapes, sterile gloves, caps and masks. The skin preparation should be done either with 70% alcohol or 10% codeine iron solution or 2 to 4% chlorhexidine. But now what in ICU setups we all of us use is chlorhexidine solutions. So this is how a patient should be draped, because sterile precautions are very important for central line insertion, because the catheter related infections are very high because of the aseptic precautions are not strictly followed. This is the central line equipment. This, I think all of you would have seen, this is the kit which will be available to us. So as you can see in this slide, you can see there is a needle which is required for the venous insertion. This is the guide wire. This is the scalpel which is required. And here you can see there are 3 lumens. This is a central line catheter with 3 lumens. There will be one 16 gauge and two 16 gauge and one 18 gauge for IV fluids or blood transfusions. And this is the dilator which will be used for dilatation. So what is the procedure which we do? So first, as I was telling you in the previous slides, the sterile preparation, the landmarking of the access site. After which you have to depend on, next is moving on to is the anesthesia. If the patient is on ventilator, patient is already on sedation, we can directly go ahead and place the line. In case patient is awake, conscious, before doing all this, we have to explain to the attenders that get consent for the central line access, and then explain to the patient before we start to move on to the procedure. If the patient is awake and conscious, we have to give local anesthesia at the site of wherever we are going to insert the central line. After giving that, now first, there are 2 ways you can do this procedure. One is landmark guided, one is ultrasound guided. The landmark guided procedures have been slowly moving out of date, and all of us have moved towards ultrasound guided procedures. Mostly in the OT setup and ICU setups, we have moved towards ultrasound guided procedures. In the next coming slides, I'll tell you how we do an ultrasound and how we identify the vein. So after we identify the vein, the introducer needle will be placed in the vein, and then you have to check whether it's a venous or an arterial blood. After that, you have to insert the guide wire, remove the needle, place a skin incision, and then dilate the axis, and then place the catheter. After placing the catheter, you have to be very careful to remove the guide wire. After which, you have to flush and cap the lumens and secure the catheter. 2 important things is here I've marked it in red because there are a lot of incidences where the insertion of the guide wire, if it is not going freely, do not push the guide wire because your access may not be in the right location. So make sure that there is free aspirate of the blood before you insert the guide wire. And if there's any resistance while inserting the guide wire, make sure that you pause, reassess, and then you insert the guide wire. The other important step is removal of the guide wire, because there are a lot of incidences where guide wire has been pushed inside and patient has been pushed to the cath lab to remove the guide wire. There are a lot of complications if the guide wire is left in place. This is a pictorial demonstration which I was telling you earlier. This is, you can see there is an aspirate of blood when the needle is inserted into the vein, after which a guide wire has to be inserted through the needle. Then the guide wire will be there and the needle will be removed. After which, you have to place a dilator. After the pathway is dilated, then you insert the catheter and then the guide wire should be removed. Then all the 3 lumens should be capped. So there are 3 approaches which I was telling about: the internal jugular, femoral, and subclavian. We'll be discussing in the next 5 minutes the advantages and disadvantages of each approach. For the internal jugular approach, right side approach is preferred, and you can place the patient in Trendelenburg position. The head should be slightly turned to the opposite side. The needle placement is a triangle formed by the clavicle and the sternal and clavicular heads of the sternocleidomastoid muscle, after which the needle should be placed at 30 to 40 degrees to the skin and lateral to the carotid artery. You should always aim towards the ipsilateral nipple under the medial border of the lateral head of the sternocleidomastoid muscle. So this is a pictorial representation which I was talking earlier. See, the needle has to be directed towards the ipsilateral nipple, lateral to the carotid artery. These are the 2 heads of the sternocleidomastoid muscle. This is an ultrasound image of the internal jugular vein. Here you can see this is the internal jugular vein. This is the carotid artery. How do we differentiate between this? Either using a color Doppler or you can do a compressibility test. When you try to compress, the veins are always collapsible. So you can see if you compress this, the internal jugular will collapse. So it's easier for us to identify that this is the internal jugular vein. In this, you can see the needle will be entering into the internal jugular vein. This is a small demonstration video of how internal jugular landmark guided approach has been done.
With the patient in the supine position, locate the important anatomical landmarks. Palpate the carotid pulsation and identify the anterior and posterior heads of the sternocleidomastoid muscle. Make certain you can identify these landmarks before proceeding further. Here, the physician.
So once after you've identified the landmark, then you have to do, here they've used povidone, but now we've moved on to use
You can make the
for
sternocleidomastoid more visible by having the patient rotate his head to the contralateral side and flex his neck. Once the betadine is dry, place a sterile dressing on the patient. For local anesthesia,
so as I was telling you, after this,
you must maintain constant negative pressure on the advancing.
So after this, you can see they're giving a local anesthesia at this place, and then they're locating the vein. So once you can see, just pause it for you people to see. So you can see the color of the blood is dark color, and the flow will be, there'll not be an arterial pulsation. So this is for us to identify that this needle is in the internal jugular vein. So here you can see after the needle is placed, they're threading the guide wire through this needle. After they've threaded the guide wire, they are removing the needle. So once the needle is removed, they're placing an incision at the place. So once the incision has been placed, then you dilate dilate through the guide wire. So he is inserting the dilator. So you have to make sure always the guide wire is pulled out and the guide wire is held with one of the hand when you insert it. So you can see here, he is always holding the guide wire and the guide wire is always outside. So after it is done, the catheter is inside and then you have to check for the backflow. Once you have checked for the backflow of the catheter, in this, it is because a landmark guided, they are checking like this. If we have done ultrasound guided, we can see the catheter insertion through the ultrasound real imaging. And after it is done also, we can check if the catheter is in the jugular vein. After which suturing has to be done. Both the sides suturing has to be done. See, tight suturing has to be done 1, 2, and 3. All these suturing has to be done. After the suturing is done, a sterile dressing has to be placed. So once you have placed the internal jugular catheter or central line or a dialysis catheter, we have to take an X-ray to confirm the position of the internal of the catheter. So here you can see the catheter right sitting into the junction of the SVC and RA. The other things which you can do instead of an X-ray is you can do an ultrasound screening to see where the catheter is. The next thing is for looking for pneumothorax, because that is the most important complication after the internal jugular vein or a subclavian cannulation. So to rule out a pneumothorax, instead of taking an X-ray, we can do a lung ultrasound to see if there's any lung sliding present or absent. If the lung sliding is absent, that means patient has pneumothorax and it is iatrogenic because we have caused the pneumothorax because of the central line cannulation. So next, moving on to the advantages and the disadvantages of internal jugular. The anatomy is readily visible for us with ultrasound, easily access surface to the patient. What are the most important disadvantages are there is a puncture of the internal carotid can happen and pneumothorax can happen. Next, moving on to the subclavian approach. So in the subclavian approach also right side is preferred. As for both the internal jugular and the subclavian, why did I say right sided is preferred? Because most common thing is in the left side, the length of the catheter has to be chosen when you have to do because of a longer length required. The other thing is injury to the thoracic duct. In the subclavian approach, the supine position, head neutral with arm should be abducted and shoulders should be neutral with mild retraction. The needle placement will be the junction of the middle and medial thirds of the clavicle at the small tubercle in the medial deltopectoral groove. Needle should be parallel to the skin and it should be aimed towards the supraclavicular notch and just under the clavicle. So here you can see it is just under the clavicle. You go straight, hit the groove and go below it and aim towards the sternal notch.
Evidence suggests that the risk of major central venous line.
So this is a representation of the subclavian approach. Here you can see this is the subclavian artery and this is the subclavian vein. So as I was telling you, you have to palpate for the clavicle. So after you palpate for the clavicle and the sternal notch, go below the junction between the medial 2/3 and the lateral 1/3, go below it and then aim towards the sternal notch. So once there is a blood aspirate, this is the triple lumen catheter which we were talking earlier. The same thing has to be placed here also. So here you can see how he is accessing the subclavian vein. So once he inserts into it, blood is aspirated. The same thing here also, the blood should be dark in color and there should not be any pulsatile flow. After which a guide wire will be inserted into the line. Needle will be removed. then placing an incision with the scalpel, and then the dilator will be passed over the guide wire. So once the dilator is passed over the guide, here you can see how he is dilating it. The rotatory movements are very important in dilating any vein. After you have dilated it, then pass the catheter over the guide wire.
Place caps on the hubs and secure the line in place. Apply a sterile dressing before removing the drain.
So here you can see how he placed the sterile dressing, which I was telling you in the earlier.
Secure the line in place. Apply a sterile dressing before removing the drain. Obtain a chest X-ray to assess for proper placement and to assure that no hemothorax or pneumothorax has occurred. All sharps should be properly disposed in approved sharps containers. Scalpels should be retracted into their protective sleeves. Needle stick injury can be minimized by using needle lock devices found in most commercial central line kits. Sterile dressing should be placed on the insertion site. The dressing should be changed daily, and whenever blood or liquid accumulates or it loses its feel.
So regarding the advantages of subclavian vein, there is a lower risk of infection, does not require movement of patient's head, and can be assessed during C-spine immobilization. It is useful in emergencies. The most important thing is the subclavians are preferred because of the lower risk of infections. But the other disadvantage is it has highest chances of pneumothorax, the puncture of the tracheostomy or the ET tube cuff, and you cannot apply pressure to stop bleeding. So when a patient comes in emergency, when patient PT-INR are elevated, when patient is in sepsis, septic shock, bleeding, we usually prefer the internal jugular or the femoral vein because if it bleeds, we'll have access to stop by applying pressure. Next is the femoral approach. So position is supine, needle placement is medial to the femoral artery. Needle should be held at 45-degree angle and skin insertion should be 2 centimeters below the inguinal ligament. And you have to aim towards the umbilicus. Here you can see this is the femoral vein, this is the femoral artery, and this is the femoral nerve. So the vein is the medialmost structure. So here you can see this is the inguinal ligament, this is the femoral vein. This is an ultrasound image of showing this is the femoral artery and this is the femoral vein. As I was telling you earlier, the femoral vein will be compressible. When you try to compress, the femoral vein is getting compressed. Here you can see in this picture. So this is how you can differentiate. Otherwise, you can use a color Doppler also to differentiate between the femoral vein and the femoral artery. Safest vein to place large lines. For example, veno-vena hemofiltration, usually they use it for ECMO. Femoral artery puncture can lead to retroperitoneal bleed. Femoral nerve damage can occur. And the most important disadvantage of a femoral vein is highest chance of infection. So usually we do not prefer femoral veins until it is a very, very emergency. So after we have placed the catheter, what is the post-catheter placement? What are the steps to be done? Aspirate blood from each port and check. Flush with saline or sterile water and do not use heparin. Secure catheter with sutures. Cover with sterile dressing. Obtain chest X-ray for IJV and subclavian lines and write a procedure note. So always remember, after placing all these, procedure note is very important and documentation is very important. So the name of the procedure, indication, and how many pricks you have done should also be mentioned. So as I was talking to you earlier, the ultrasound guided central venous access has become the standard of care now. Veins are compressible. Vein is accessed under direct visualization, and it is very helpful in patients with difficult anatomy. Before we start on to do a cannulation, we have to always check whether there is a thrombus, whether the veins are compressible, because there are a lot of patients who are chronic renal failure patients who would have had multiple dialysis lines inserted and the veins would have been thrombosed. This is a small video to show that you can see a thrombus over there. So here you can see a lot of echogenic structures, the thrombus. This is when a patient who was multiple times catheter was placed for dialysis because a fistula could not be done for the patient. So here you can see the thrombus, the echogenic structures which are moving around. So always remember, before doing any ultrasound cannulation, screen for the vein and see if there are any echogenic structures or it is compressible. So this is again a recap of what we have been talking. So first confirm the anatomy, after which use an ultrasound probe to see the location. Then you with the ultrasound, puncture the vein. Then the guide wire has to be inserted. After the guide wire inserted, use a dilator to dilate it. Remove the dilator, place the catheter, aspirate and see if there is blood flow in all the three sides. After which it has to be capped and a sterile dressing has to be placed. So as I was talking about dressing of the site, use either sterile gauze or a semi-permeable dressing. You need not replace the dressings daily. But if it's a gauze dressing which you are going to do, you have to replace it every 2 days. But if there are transparent dressings, it can be changed every 7 days. But in case if there is a soiling of the dressing, it has to be changed immediately. So insertion related complications, there can be pneumothorax, chylothorax, hemothorax, cardiac arrhythmias, air embolus, arterial puncture, and nerve injury. Mechanical related complications are poor catheter placement. It can be high and up or it can be very low down. Phlebitis, thrombosis, and catheter occlusion can occur. Infection related, there can be a catheter insertion site related infection, a tunneling, there can be a subcutaneous infection, there can be colonization and bacteremia. So the summary, vascular access devices are very important because in any emergency condition for giving high inotropic support fluids in trauma resuscitation, we might need central line accesses or dialysis line accesses. If patient comes with high potassium levels, we need immediate. So very important is the device and the site selection. I forgot to tell you about the catheter sizes. Usually the central line catheters which we use are 7 French catheters. And the dialysis line catheters, the right-sided IJV catheters are 13 French and the left-sided IJV catheters are 16 French. So device, site and size are very important. After all these have been done, nursing care is more important because high chances of central line catheter infections have come. And once that infection is that patient goes into bacteremia sepsis and then we'll not be able to use that access anymore. So we have to remove the lines and resite the lines. So in any emergency condition, if these lines are placed, it has to be resited as early as possible. Thank you.
Thank you.
Thank you, Dr.Sasi.
Thank you, sir.
This presentation. We have some questions here.
Yes, sir.
So why you are emphasizing that the heparin should not be used?
So because there are high chances of bleeding in sepsis patients, sir, and heparin is not required for line flushing, sir. Only saline flushing is enough, sir, to maintain the patency of the lines.
Okay. Can we use EJV instead of IJV in critically ill patients? For
we can use EJV, sir, but if the access is enough, if patient is not requiring dialysis or anything, we can use EJV itself only for inotropic support. If there's a worsening inotropic support when patient is going to require dialysis, instead of putting an EJV, directly we can put a triple lumen so that we can use it both for dialysis, for fluid resuscitation, for inotropic support. Otherwise, if you put a right EJV already, then we have to place a left-sided line, sir, when patient is very sick. So left-sided EJV, left-sided IJV when you place, you need to use a longer catheter. There are more chances of thoracic duct injury and everything in an emergency situation when you're doing it. So usually we prefer right-sided IJV, and in case we are going to place an EJV initially, till we place the line and everything, we usually use a left-sided EJV for initial starting, and then we move on to right-sided IJV.
Central line placement in anticoagulated patients. In anticoagulated.
In anticoagulated patients, depending on the emergency, sir, we usually look into the platelet count and PT-INR values. If the platelet count is less than 50,000, if the patient requires a dialysis line and if platelet count is less than 50,000, we prefer to transfuse and then place a dialysis line.
No, what about for central, not dialysis catheter, central line?
Central catheter, we do it till platelet count of 20,000, sir.
Okay. No, what is the size of the catheter which you...
7 French catheter, sir.
No, why 13 French catheter for right IJV and 16 French catheters for left IJV during dialysis?
During dialysis, because of the SVC-RA junction, the catheter tip has to be there, sir. So when it comes from the left side, the catheter tip is high up. So the flows will be, when you do during dialysis, it gets stuck, sir, if it is not in the right position. So left-sided are longer to approach the junction of SVC and RA. So that's why we use 16 French for left-sided and 13 French for right-sided.
Thank you. Thank you. You answered all the questions. Thank you, Sasi. Thanks
Thank
a lot. Edward, sir, over to you, sir.
Thank you, sir. Thank you. So the three presenters, Dr.Aarthi, Dr. Prateema, and Dr.Sasi, I thank the today presenters. Excellent presentations. And with that, we come to the end of this session. I thank the coordinator Rajesh, Jeyaprakash sir also. And I thank the Anaesthesia TV, A1 Logics, and Acrola for this session. And we will meet the next week with an interesting topic on ventilator, that is basic modes of ventilator by Chandrasekhar sir. Thank you, one and all. We will conclude this session.